So they're probably familiar, these folks, to most of you guys. And there are bios, I think, and you received coming in. But I'll just say very briefly a word about each, starting with Madam Secretary Kim Belcher, who many of you know most recently was the Secretary of Health and Human Services in the Schwarzenegger administration. I had the privilege of serving with Kim. She's now at PPIC as a fellow, and I'm just starting to hear about her plans there, but it's all good and exciting. And of course, she is one of the distinguished members of the California Exchange we're here to talk about today. So she's going to reveal all in terms of what is going on there. And she's just back from Patagonia on a trek, so that's why she's glowing. And then after Kim gives us kind of an overview of what she knows about the exchange and other things to tee us up, then Anthony will start with the consumer perspective. Most of you know Anthony, a tenacious fighter for consumer rights at Health Access. You should also know, if you don't, that he's from the Bronx, so he's tough, but he's tough on behalf of consumers, so that's a good thing. And then we'll go to then we're going to go to Chad from there, one of the rising stars up here on the panel from the Latino Coalition for a Healthy California, who many of you know are leaders in access to quality care for Latinos, regardless of immigration status. So thank you for being here, Chad. And then we go to Patrick, right? Who will have a different view from Anthony on some things, I hope, I'm counting on. And as always, Patrick will be a reasoned voice, as he was in the state Senate, and he is at CAHP. Even when we disagree, he's never disagreeable. And then we'll wrap up with Alex Barrios, another rising star up here on the panel, who is known, he was a field rep for Dave Jones, now a principal at Axel Communications, has earned a reputation for being someone who's good at bringing people together, and he did that today. He brought us together up here, and he got you guys here somehow too. So thank you for doing that, Alex. And you'll wrap up by talking about the communications aspect of this, so we're sure that we're not just having a conversation among ourselves, but we're actually talking to those tens of millions of people out there in California who will be affected by all this. So we're going to start with Madam Secretary, Kim Belcher.
It sounds so formal and so long ago.
Less than 90 days.
Less than 90 days. So my trip to Patagonia was fabulous. I'm a big believer in taking time after jobs. But in all seriousness, I'm delighted to be here and talk a little bit about the Health Benefit Exchange. And Daniel's asked me to say more than just a few words, just to kind of provide a framework for our discussion about the exchange and strategies for success. And there are really three principal, there's 2 seats down here for folks who are just arriving, unless those purses absolutely need a place to sit. But there are really three principal messages I want to leave with you this afternoon. Number one, through the legislation that's been enacted creating the Health Benefit Exchange, I think we really have the tools. We have the tools to extend coverage to millions of Californians and the opportunity to do so in a way that really can promote a higher performing delivery system in terms of improved outcomes, improved quality, improved in terms of lesser costs. So we need to think about and use those tools wisely and strategically. Secondly, while benefit design and coverage is critical, we can't lose sight of the fact that eligibility enrollment systems and processes really matter to consumers. And so we need to design those systems in a way that are maximally consumer-friendly, efficient, and successful. And finally, I want to leave you with the observation that, yes, this exchange is a shiny new object that we're all very excited about, but an exchange is not a Christmas tree. So I'll return to that in a moment. So what is an exchange? It is an exciting and I would argue probably the critical centerpiece of health reform. It is a new competitive marketplace that is going to enable consumers to compare benefits and purchase health insurance. It's the place where people can go to use that tax credit to access affordable coverage and to meet the requirements of federal law relative to the individual mandate. And it is a vehicle for promoting more competition among health plans and insurers on the basis of price and quality and service, or what we often refer to as value. There's tremendous potential with the exchange. First and foremost, it is about extending coverage to the millions of Californians who will be eligible to purchase through the exchange, and effectively giving them, through this purchasing option, the same kind of purchasing clout and role in the marketplace, as you will, if you will, as employees of large employers. But it has a potential to do much more than extend coverage. It does have the potential to improve the functioning of the marketplace in a way that improves quality, improves outcomes, improves the consumer experience, and slows the rate of growth in healthcare costs. Now, that is a really tall order. Now, the good news for California is that we are not having a conversation about whether or not to do it. So in that respect, we are in the enviable position of actually talking about implementation and not the political conversations about whether or not to do it. But it is not enviable in terms of the incredibly significant operational issues and challenges that we face. So how California goes about approaching these questions is really going to be consequential, because it's state policy and practice that's going to determine whether or not reform actually succeeds in extending coverage and promoting improvements in our delivery system and improving value in healthcare for consumers. So I think the focus of this conference is right on in terms of strategies for success, and I think the lens from a consumer perspective is the appropriate one. So what are some of the key decision points? There's really two areas that I want to focus on from the vantage point of a board, exchange board member. The first set of issues is really around the purpose, the governance, and the authorities that the legislature has conferred to the exchange board, and how the board decides to use those tools and authorities to bring greater value and to improve consumer choice. And secondly are the set of issues around eligibility enrollment systems and the extent to which they either hinder or facilitate coverage. So in terms of this first grouping of issues, our legislature, unlike any other state legislature other than, as of yesterday, West Virginia. West Virginia has joined the August Company of the state of California. There are not many things that we often say California and West Virginia in the same breath on, but now we can, in terms of we are the two states who have governors who have enacted health benefit exchange legislation. But our legislature last year made some important decisions and provided a very clear framework for the exchange and some important tools in terms of facilitating the exchange's ability to both expand coverage as well as derive greater value in our healthcare delivery system. The first decision they made was that the exchange was going to be an active purchaser with the authority to set plan participation standards and then select the highest value plans. Again, value being defined as price, quality, and service. This is an operating model that's very different, no doubt, from what West Virginia did and what other states may do. But it was an approach that was informed by California's many years of experience as an active purchaser in Medi-Cal and CalPERS and Healthy Families. And it provides the exchange board with a very important tool, this ability to selectively contract, a tool that can be used by the board to work with health plans and provide choices to consumers that maximize competition around quality, price, and service. The second set of decisions the legislature made was around governance. And the legislature said, even though it's an option to create a private nonprofit to administer this exchange, millions of Californians are going to be securing access through the exchange, coverage through the exchange. And it potentially has the impact on a much broader delivery system, which will affect all Californians. And we're talking about billions of public dollars that are going to be in play. So we're not comfortable having it be governed by a nonprofit. So the decision there the legislature made was to set up a new independent state agency within state government. It's not affiliated with an existing department or board, but it is a part of government. And in so doing, the legislature was very clear in terms of saying, we want to make sure, as a government entity, this board is accountable and accessible to the public. And at the same time, we want to make sure it has some flexibilities to be nimble and competitive in what will be a very competitive marketplace. So struck a very important balance there in terms of both obligations of the board to act in a very public fashion, but also some flexibilities to be more competitive in a changing insurance marketplace and regulatory context. Finally, the legislature said we want to make sure the exchange has some tools to facilitate its ability to help drive competition around drive competition around price and quality as opposed to competition around avoiding or segmenting risk. It's one of the reasons why the legislature, as I said, gave the board this selective contracting authority. But there are other tools as well. The board, for example, has the ability to authorize what's called standardized benefits, which is basically requiring plans to look exactly the same across these different tiers. And the idea here is, number one, you want to give consumers the ability to make informed choices and to really make what we call apples-to-apples comparisons of benefits. At the same time, that kind of standardization has the potential to really help mitigate risk selection that could occur if plans make variations on cost sharing or related to benefits. So again, these are examples of some important decisions that the legislature made. But as you can see, it also left important decisions for the exchange board to make. So a couple of those decisions are going to be, first and foremost, how is the exchange going to exercise this ability to selectively contract? So how is it going to employ that important tool with an eye towards providing consumers the optimal combination of choice, value, service, and quality, which is the legislative directive? How is the Exchange Board going to facilitate the shopping experience for consumers and empower consumers to make decisions that reflect their priorities, their needs around price and quality and service? How is the board going to balance, on the one hand, the important goal of facilitating consumer decision-making to make these apples-to-apples comparisons of plans, but at the same time encouraging innovation in benefit design by health plans? So these and others are some of the really important and strategic questions that the board is going to have to make. And because it is a government board, it will not be making them in private, it will not be making them in isolation, but rather through very public, open, and transparent processes. And so we will be working together, those of us who care about these issues, on these and others to really advance our collective goal in ensuring that the exchange can be successful, not just on coverage, but also in terms of driving competition more squarely around price and quality, and really bring greater value to our healthcare system. The second set of issues I want to quickly touch on is eligibility enrollment, because it's not enough to mandate people to buy something. It's not enough to offer them products that are affordable. We have to care about the systems and processes we have in place to facilitate enrollment and to retain enrollment. And in that respect, we've got a lot of work to do because we have a very complicated county-based, multi-system based approach to eligibility determination enrollment in our Medi-Cal system. And the federal government has said, you know, we're going to give you states some tools to really modernize and streamline and make more consumer-friendly eligibility and enrollment systems. And the feds have been very clear with the states in terms of how are you going to use these tools. So they've said, you know, consumers have to have a first-class retail experience, you know, on the par of Nordstrom's and, you know, really high end, harnessing the power of technology and really providing a first-class retail experience. They have said, states, you have to use these tools to make sure that you have seamless integration and coordination across the exchange, Medi-Cal, and Healthy Families. And they said you need to make sure that these tools are used to enable people to, in real time, be determined eligible and enrolled in the programs for which they're eligible. So the exchange has a very important role to play in this effort to simplify eligibility and enrollment, but it's not going to act alone. One of our first and most important decisions is going to be determine what is our role around eligibility enrollment, particularly in the context of our partnerships with Medi-Cal and the Healthy Families program. So these are three programs that are going to have to work in a very seamless, integrated, and coordinated fashion and provide real-time eligibility determination and enrollment. If our state is going to be successful in realizing the vision that I think all of us embrace of no wrong door, of really facilitating and simplifying eligibility determination and enrollment, and if we are going to give consumers a first-class retail experience, then I think all of us are going to really have to step back and reassess how we do eligibility and enrollment today with an eye towards how do we facilitate and make as efficient and friendly as possible from a consumer perspective the process, and do so in a way that meets federal direction and federal requirements. I'd close with a final comment about the Christmas tree. An exchange is a shiny new object. It's exciting, it's new, it's consequential. It is a pivotal part of reform in concert with a comprehensive set of strategies, no question about it. It can do more than extend coverage to millions. I really want to underscore that, properly designed, properly implemented. But notwithstanding that potential, I think it's really important that we not look at the exchange as a Christmas tree, you know, as a vehicle for solving all the myriad pent-up demands and issues and concerns around access and quality and cost. Because I worry that if the exchange becomes the answer, the solution to all of our problems, then the exchange risks failing on all fronts. So I close on a positive note, which is we just have an extraordinary opportunity before us. I am proud that our elected officials last year demonstrated considerable courage and capacity to deal with some very difficult decisions They provided the Exchange Board with very important tools as well as direction. And I'm confident that working together in open, transparent processes, we are going to be able to advance the goals we share in terms of improving access, affordability, and quality for the millions of Californians who will rely on the exchange for coverage and potentially for the broader marketplace more comprehensively. So look forward to working with you in that effort. Thank you.
So good afternoon.
Good afternoon.
Oh, man.
Good afternoon.
Okay, let's try this again. I know it's after lunch, but good afternoon. Good afternoon. Thank you. My name is Anthony Wright. I'm the Executive Director of Health Access California. We're the statewide healthcare consumer advocacy coalition. And very excited to be talking this year and for the last year about implementing health reform as opposed to the 23-odd years of my organization's work trying to pass some version of health reform. But it is not just about implementing, it's also about improving upon, it's also about continuing the work of health reform. It's not like health reform started in 2009 or in California in 2007. There has been iterations, and there will continue to be iterations to continue to improve our healthcare system. However, it is an important status report. In the back table, we just put out a report because it has been 1 year since the passage of the act, and we just celebrated it on March 23rd, and so we have a report on the one-year status report on how we are doing as California in implementing that law. It's also available, and feel free to follow us on our email and blog and Twitter and Facebook to continue to get updates about that effort. But I'll refer to this at the end because at the end there's not just a list of what we've done, but what is yet left to do in terms of bills that are pending in the California legislature and actions that still need to be taken at our two regulators, Department of Managed Healthcare, at the Department of Insurance that we heard from our Insurance Commissioner Jones about. In terms of specifically the exchange, that's obviously where a lot of folks are going to be looking as the shiny new object, as the new game in town. People are all very interested in where it's going to meet and when it's going to meet and how many times it's going to meet and all the things that we don't exactly know right now. I do think that I want to just to put this in context. The exchange is not all of health reform, but it's a crucial point. It's most people who have employer-based coverage will continue to get their coverage through their employer. There will be additional. What the health law does is stabilize employer-based coverage through tax credits and requirements on large employers. For public programs, benefits would be improved, and in the case of Medi-Cal, the program will be expanded and streamlined. But this is for the individuals and small businesses who otherwise don't have coverage. This will be the venue, the prime venue for them to get that coverage. A major venue within the current individual as well as small group market. And it is the most dramatic reform of those three ways that people get coverage. And the reason why it's the most dramatic is because it was the most broken. That previously individuals were all alone at the mercy of the insurance industry. They had no bargaining power, and as a result, it's the least efficient, most expensive way to get coverage right now. And so this is an attempt to try to solve some of the many problems that existed with the experience of individuals trying to buy coverage right now. The big thing that all exchanges, whether they be in West Virginia or California, have to do is to deliver subsidies so that people can better afford coverage. And I think that it's important just to reflect on this for a second, that this is a sea change in the way that people experience buying health coverage. We are moving from a world where you pay based on how sick you are to a world based on you pay based on what you can afford on a sliding scale, where the subsidies in exchange will make it so that you do not have to pay more than a certain percentage of your income on a sliding scale between 2 and 9.5%. And if the coverage costs more than that, the subsidy will make up the difference. for the coverage that you want. It is, it's a pretty dramatic sea change in people's ability to afford health coverage in what has normally been a very regressive manner. But I think that but let me focus on moving forward, what this exchange can do, and I think some goals for the exchange. And Secretary Blanchet, I think, correctly pinpointed the whole issue of eligibility and enrollment, because its primary focus is to create a simple, easy, consumer-friendly way for people to be able to get coverage. Right now, that it is complex, it is confusing, and that is as much an issue along with affordability, along with it being denied for pre-existing conditions, that people don't get coverage. I mean, there is evidence in the academic literature that with the dizzying amount of choices, people get stymied by just that complexity, just that confusion on this kind of issue. And so, but in terms of eligibility enrollment systems, I think that the state, and our advocacy is targeted at having the state take up a goal of eligibility that is not, that on the first day that the exchange is up and running with those subsidies, on January 1, 2014, that we don't enroll 100,000 or 200,000 or 1 million, but that we have a goal of 2 million plus in coverage in Medi-Cal and in the exchange on January 1, 2014. Many of us saw the S-CHIP program, Healthy Families, which important program, key program that started, it took us years to sort of get up to the hundreds of thousands of kids in that program. And I think the question is, how can we get out of the gate on day one in terms of having lots of people? And it's not just an impulse of making sure that people have care that should drive us. It's also basic economic policy. In Medi-Cal for the first 3 years, the newly eligible are 100% federally funded. In the exchange, all the subsidies in perpetuity are 100% federally funded. So for every day that somebody is not enrolled in coverage, we are losing federal funds that are left in Washington, D.C. And so then the question is, what do we need to do that? What systems do we need to put in place between now and then, in the few short years we have between now and then? What are the ways that we can identify existing populations of people who we know are eligible, and get them informed and enrolled in 2012, in 2013? And so we do have bills in the legislature to try to start that process. There's a bill by AB 714 by Assembly Member Atkins that tries to identify populations, whether it be Family Pact or the parents of Healthy Families children or others, to say how can we give them notice in 2012 and start actually having them go through process so they have the card of coverage in 2014. Post 2014, another bill that we're working on is AB 792 by Assemblywoman Bonilla that talks about automatic enrollment, that really targets at what are the places that when people become uninsured, how do we make sure that they automatically get into the exchange? In the times of life that people have those transitions, they lose a job, they get a divorce, they graduate from college, all of those mechanisms that they automatically get in. And then I think a third, Western Center on Law and Poverty has a bill, AB 1296 by Assemblywoman Bonilla as well, to do some of the beginning of the streamlining of our eligibility enrollment systems in Medi-Cal and other public programs. So that's just a taste of, I think, what we should establish as a goal for the state and ways that we can get there. We can do this if we start right now. I'm excited about the possibility of everybody having a purchaser on their behalf, much like workers of large employers do. I also think that metaphor should be expanded. I think that the exchange really can act as the HR department for the rest of us who don't work for Google. And so in terms of providing that purchasing power, that sense that somebody's going to be vetting the packages in the plan so that there isn't some junk coverage that if I select this plan, suddenly there's going to be some loophole that's going to where I'm going to find that something that I thought was covered is not covered. Again, much like you would expect a large employer to do on behalf of their employees, providing that trusted source of information as people deal with their insurer. And then finally, the thing that I would say that we need to do in this interim period is and I think that this is very true in terms, just to piggyback on what Secretary Belcher said, is that it's not just that the exchange can't be the only vehicle by which we achieve our goals, because we don't want the exchange to be adversely selected against the rest of the market. And so so to the extent that we want to put in place consumer protections, that needs to be done both in the exchange and outside the exchange. That needs to be done through policy. And in fact, the more we can do that, including some of the protections that are in 2014, and do that early to phase it in so that this doesn't all happen as a shock to the system in 2014, but that we phase it in, the more that we prevent insurers from gaming the system between now and 2014 when we have a new market and a new set of rules moving forward. So those are some things to think about in this interim period as we head toward it. My final point, as we segue to my consumer advocate colleague, is that most of us, this is sort of the world between Medi-Cal and the private insurance market. This is the world between, and it has to be almost a bridge between these worlds. It has to be both something that's well integrated with Medi-Cal, with Healthy Families, and it has to be something that is well integrated with private employer-based coverage, private insurance. It is not your grandfather's individual market. The population in the exchange, as Chad's going to talk about, is going to be 2/3 families of color. He's going to be half Latino. I mean, I actually think it should probably be called El Mercado rather than the exchange. And I think that has implications as well that I know Chad will go into. So thank you very much.
Hello. Well, as a colleague of mine said, Ruben Lizardo from over at PolicyLink, as Latinos go in California, so will go California. We have the youngest population right now. I know LA Times had an article out this morning that said that the majority of children right now, majority of young people are children of color, and that by 2050 it'll be a predominantly Hispanic or Latino state. And so with this in mind, we have to look at the exchange through the lens of, well, how are we going to get people enrolled? What things do we need to do to get this burgeoning majority population now into the exchanges? And of course, Latino Coalition, we've been discussing, linguistic and cultural competency for quite some time. And so the first point I would make is that is something that needs to be structurally built into the exchange. That is not just for the sake of Latinos, but for all communities of color. As California attracts and has a higher population of immigrants recently arrived than otherwise in most any other state in the United States. So therefore, with regard to getting them enrolled in the exchange, those enrollment efforts need to have within it the component of linguistic and cultural competency. Why this is important? Well, again, we go back. What are some of the things that the ACA is going to bring to the table? Well, for communities of color, for those who have suffered disproportionately because of lack of access, many of these issues have to deal with prevention. And of course, we know the ACA is going to provide assistance with regard to preventative services now going to be available by insurance, and so and the investments into community-based prevention efforts. Why is this important? Again, we go back to the youth of the population, the Latino population. It's essential that our enrollment and outreach efforts are addressing this very young and vibrant population. If we can get people enrolled early and get them involved with these prevention efforts, that represents a great cost savings down the line, presumably, for the system in general. Because now, instead of dealing with tertiary care, now instead of dealing with, things as they become chronic, now we're dealing with things before they get there, which is also a considerable reduction in costs. This is also important to the Latino population because, as many of you may know, we suffer disproportionately from certain forms of chronic disease. There's certain forms of heart disease, diabetes, and if you're Boricua like me, hypertension tends to be an issue. And so having prevention is built in, and having access to prevention is very essential to our population. Again, going back to the youth, it's getting started early. So what does that mean? Well, that means, again, we go back to linguistic and cultural competency. That goes back and making sure that the messaging goes out in a meaningful way that is readily understood by the populations we're trying to address. But again, the Latino population is fairly complicated itself, because we're not only dealing with recently arrived immigrants who are Latino, but we also have well-established Latino families who have been here for, well, in some cases, centuries. So we have Californios, we have Chicanos, we have recently arrived immigrants, and all those require just a little bit different form of messaging. But in the end game, what we really need to address is make sure that this is built into the system at the very beginning, that this isn't a knee-jerk reaction, that these things are something that every time we say, every time we engage in an outreach effort, we're always doing it through this lens and making sure that we are addressing the population, one, where they live. Which brings me to the subject of technology as a form of outreach, the whole exchange of the IT outreach efforts, of constructing websites as a means of getting people to the information they need. Well, of course, we're talking about some populations that don't have the access, nor do they have the bandwidth. So while they may have access to internet, they do not have broadband in their homes. This is particularly true of recently arrived immigrants, Latino immigrants specifically as well. So that may not be the most efficient way to get the message out and for them to get the information. And once again, we get to how complicated all of this is going to be when you're trying to measure what plan is better than the other. So in which case, we need to make sure that there is assistance. In which case, drilling down to the community level is essential. Whether that be through the Navigator program or the community health clinics are now engaging in the Ambassador program, which is education for for people working in the clinics to make sure that they're getting information to the people who come and visit their clinics. This is essential. Drilling down to the community level involving CBOs. The people who work in the communities are the best situated to communicate the importance of the ACA and to do it in a way that is readily understood and really is acceptable. Because there are certain ways of imparting information that may be acceptable to one population but are not acceptable to another. Massachusetts has discovered this. They've realized after the fact that the Latino population was not adequately engaged in the process. California is now in a position to take this to heart and now engage and make sure that this community again is engaged, because, as I said at the beginning, as the Latino population goes, so goes the rest of California. Thank you.
I represent the health plans. That includes the commercial plans, some of which are for-profit businesses, some of which are not-for-profit organizations, and some of which are public agencies that provide services principally to Medi-Cal and healthy families, and do so in contracting with the state. As Kim indicated, we have much to build on here in California, and we ought to do just that. And the legislature, in passing the law, has entrusted the responsibility of organizing this marketplace, supervised and regulated by state government, in order to increase the opportunity and guarantee access to people who need health care and need oftentimes assistance to purchase that. Anthony's comment that the basis of what you will be charged will not be your health status, but what you can afford, is a very pithy explanation of what the new law can afford. That is to say that very poor people will be able to take advantage of Medi-Cal more than in the past, whether they have children or not, and others will join the exchange, not isolated, one at a time. And the reason why pre-existing conditions, that is your health status, has been a factor in how much you pay is that people can come and go and buy insurance or not buy it. So were Anthony still in the Bronx, in New York, and wanted to buy individual coverage, although I suspect he's very healthy, it would be more expensive as he aged and as his health status changed. Because in New York, it's been the law that everyone has to be charged the same without regard to their health status. Very attractive if you're sick, but if you're healthy, you say, I think I'll wait because they have to sell it to me at the same price no matter what my health status. And as a consequence, you have this, competing values. Everybody gets coverage in New York at the same price. The problem is the price keeps going up because Americans are wise consumers and they can wait. So the new federal law and state law now in California corrects those market conflicts with people's own ability to get good health care. Health plans, businesses, private, for-profit, or not-for-profit can't correct that. So the marketplace will do so in combination with a law that says everybody has a responsibility to have health coverage. If you can afford it, buy it on your own. If you can't and you're poor, there are public programs. Or if you're in between, we're going to assist with a subsidy, and you buy it through the exchange. Health plans as businesses had lots of different things that you could buy, trying to appeal to the benefits you wanted, the hospitals you wanted to see, to go to, the doctors, but also trying to hit a price point and therefore changing how much the individual had to pay when you went to the doctor or went to the hospital. The standardization of those benefits that is coming that Kim referred to will help people be able to shop, and then hopefully when they decide how they want to purchase health coverage, both draw the subsidy that they're entitled to based on their income, so it's affordable, and then shop based on quality as they see it and price. In California, this is a big challenge for the exchange. We have one state, but many regions, they look very different. Some very rural, some medium rural, some very intensely urban. Demographics are quite different, and as a consequence, sometimes the services are too. The exchange's challenge, which the health plans have a duty to help with, is to see that as this goes forward in 2014, whether you're in San Diego or in Red Bluff, you have choices. And that those choices, in any case, give you a rich set of necessary health care benefits, those essential benefits to be determined at the federal level and implemented at the state, number one. Number two, that with those benefits, there are a sufficient network of providers, primary care specialists, hospitals, and of course medications. This will undoubtedly differ based on the part of the state. But by having a competition where you can pick the network and pick the price, then that competition will work for consumers. And whether you choose a public agency plan like LA Care or Health Plan of San Francisco, or whether you choose Kaiser, or whether you choose one of the other commercial plans like HealthNet that's for-profit, you then will be in control. And as to the quality, I think that the exchange, as Kim indicated, does offer the opportunity to get better data on quality. That's both the performance of the health insurers and also the performance of the hospitals and doctors. But we can build on what we have. The Office of Patient Advocate that we have, Sandra Perez is here, that's director, has a report card. The report card you can look at right now. It's user-friendly and find out how health plans and how medical groups are doing. We can build on those. The Department of Managed Health Care, the regulator now of the health plans for 21 million Californians, also has a help center, and it assists not only consumers, but it also has the ability to assist providers to make sure that they're paid. We have much to build on here in California. The exchange challenge is enormous, and we have a commitment to make it work for the consumers. And will it work for the health plans? Yes, it will, because then health plans' value added is finding out and setting up an adequate network with doctors and hospitals, making that available, and competing not on whether a person is sick or well, but properly on the quality of services.
Great, thank you. First, before I start, I want to make a couple of comments. First, I wanted to say that in regards to what Anthony said about calling the exchange El Mercado, in terms of a communications perspective, if we could get every mercado in the state of California to promote the exchange, I'd consider it a success. So thanks for that comment. I hadn't thought about that before. Second, I want to thank all of you who are here. As you know, Axel Communications, my company, helped put this event together. And so part of the reason we did this is we wanted to make sure that we started talking about these issues. And it is a fact that we haven't communicated enough about this. And I think the turnout here today and the amount of interest in this subject is an indicator of just how much interest there really is about the exchange and what it can do. And so I want to thank my fellow panelists and also those of you who are here today for talking about this issue. I'm going to talk about the communications and outreach approach to the exchange. And some of my strategies for success for doing this well is we have to do three things. One, we have to make sure that we communicate well internally amongst ourselves. The exchange is set up through several different agencies have a role in the exchange. There's managed care, there's the Department of Insurance, there's the Health Benefits Exchange, and then external to that, there's of course the health plans, consumers, and a number of advocacy groups, counties. It's a very long list of stakeholders. So if we start communicating with each other and start building a coalition around simply promoting the exchange, we'll increase our chances of success. The second point I want to talk about, and I want to keep my comments brief because I want to make sure we have time for your questions, are external communications. What type of message are we going to push out to consumers? And the third part is cost. We have to take into consideration that an outreach campaign is very expensive in the state of California, thus making the first two strategies for success, internal and external communications, extremely important. Before I touch upon those points, I want to mention one thing. How many of you have heard of, we're going to launch an awareness campaign? Raise your hand if you have heard about an awareness campaign. This exchange will not succeed simply by having an awareness campaign strategy or thinking in that mode. We have to think about adoption. People actually have to either go online or go into a Medi-Cal office or go someplace and sign up for these benefits. Otherwise, this whole thing fails. So in building a strong strategy around adoption, we have to do these three things well. We have to, number one, as I mentioned earlier, fix our communications internally. This means that right now, starting hopefully today, managed care, insurance, health, human services department, and all stakeholders start developing a coalition around outreach, with the idea in mind that we are going to start now to develop the coalition that will push this message out as we start promoting the exchange as a product, or the products within the exchange. So that has to happen now. The second thing is that we have to worry about our external communications. How are we communicating with consumers? How are we going to do that? I'm sure a lot of you on your way over here saw a lot of billboards. When you're watching TV at night, you see a lot of commercials. We tune them out nowadays. There's a lot of environmental noise out there, and so we don't pay attention to what we see until it impacts our lives. So we need to make sure that when we develop our messaging, that it's carefully crafted, that it's done in a way that will appeal to consumers, and third, that it's one message. One of the challenges that I see, because I also consult for the Health Information Exchange, is that a lot of people don't know the difference. People don't understand what the difference is between Health Information Exchange and Health Insurance Exchange. And I'll admit that I was guilty of that just a year ago. So there's a lot of confusion, and we have to make sure that we communicate one message. And that healthcare reform message has to be something simple to the point that will drive people to things like a website or to a local office where they can sign up for these services. The other part of our external communication strategy is that we really have to, again, focus on adoption. We're trying to get people to actually purchase products. It's not going to be an easy task to persuade them to do something different. But there are three principles that we need to seriously consider. One is relative advantage. How are the products on the market going to be better than what people currently have? Or why would they want those products instead of just paying the penalty? Because some people would rather just pay the penalty instead of afford or pay for a plan they may not be able to afford. Second, we have to think about compatibility, and I think this is a very key component of the strategy for Latino outreach, is are we doing this in a way that is friendly to the consumer and that is culturally competent? Or if in our strategy we're not appealing, for example, to people who aren't online and on the internet, what do we do about that? There's a lot of people in the senior population who may not use computers, may not go to a website. So if all we're doing is promoting a website, we're not going to necessarily be getting everybody. And we have to take that into consideration, especially with the Medi-Cal population, which is so important. The third part is complexity. And that kind of comes off of compatibility in terms of we got to make this easy for people. It has to be so simple that you spend just a couple of minutes to get it done, and it doesn't take a lot of time out of your day. And the third thing I wanted to talk about is cost. It is extremely important to run a strong advertising and consumer outreach campaign. And so if we're going to do this right, we have to start collaborating today, looking at our marketing and communications budgets, and figuring out ways that we can actually work together to push one message out. So those are my brief comments, and I'll let Daniel start the discussion.
So I'm just wondering if one or two of the panelists who didn't directly address prevention have anything to say about how the exchange can help to meet that promise and that demand for greater emphasis on prevention and wellness.
I mean, I think it's one of the things that if we are in a world, as Pat said, that or the world we want to be, which is where insurers are not competing on how deftly they can collect premiums from healthy people and avoid covering sick people, and they're in a world where they're competing on cost and quality, how do we include prevention in that? And so, what is the opportunity to have at the point of purchase, on the website, a metric that includes quality, that includes prevention or services, et cetera. So for example, I mean, I think it's a no-brainer, for example, to take the work of the patient advocate's report card and have that like right there, not in a website far away, but at the point of purchase, because that's when people are making their decisions, to say these are the plans that get the various stars for these categories. And the question is, the thing is that there are some things that we would love insurers and the health industry to compete on that it's the metrics. We still have some work to do to develop those metrics, but to say this plan is great in terms of what it does in terms of preventative care. The other, I mean, obvious piece of that is that, again, in the sort of the role of exchange as a HR department, is that I don't think that the exchange should be sort of a one-time experience, that you go in, you buy it, and then you leave, never to come back again. I think there should be an ongoing relationship, much like an HR department has, and one of the things that it could provide is information to remind people about, for example, that under the new law, you no longer have to pay cost sharing for preventative services, or what are the other options that are available outside of the health insurance world even to stay healthy so you don't have to get sick. So those are some particular things that we would be excited to for the exchange to look at as part of this broader rubric.
I'd piggyback on Anthony's comments. Number one, I think the exchange can bring value in advancing a prevention agenda through information, through transparency, in terms of providing consumers with prevention-oriented metrics around health plan performance that can help inform and drive their decision making. So number one is this issue of information and transparency. Secondly, I think there's opportunities with the exchange as a purchaser to identify collaborative opportunities with other purchasers, whether it be Medi-Cal, CalPERS, Healthy Families, large business coalitions such as the Pacific Business Group on Health. I think there's opportunities for purchasers to come together and identify specific goals they share, and to use that purchasing power to advance goals, and certainly any number of them could be prevention in nature and orientation. And finally, I think there's an opportunity, at least the last one I'd mention here, is around benefit design. And I think the exchange has an opportunity, working with the plan and provider community and consumers, to look for opportunities to support the offering of benefit designs that bring a particular orientation to or focus on prevention in terms of incentivizing more individual engagement in their health and well-being, and participating in preventative and early intervention type activities to forestall more serious and more costly health problems. So I think there's a number of tools we'll have an opportunity to employ.
Terrific. Thank you, Kim and Anthony. Okay, it's your guys' turn. Raise your hands. I'll come to you with the mic. I want you guys to stir it up a little bit. I was hoping for a little more Jerry Springer up here. The closest we got, I don't know if you guys noticed this, but Patrick said he suspected Anthony was in good health. He didn't say, I hope Anthony has good health. So. And tell us who you are, please.
Carlos Ramos. I actually had a question, but the last question that you asked kind of inspired me to also offer a comment. I think in terms of prevention, one of the things that you folks ought to look at, both the health plans and maybe the exchange, is look at what other industries are doing, and maybe try to learn and emulate some of what they're doing. As an example, every time I get a statement from my credit union, they send in my monthly statement, little things that to me seem like, wow, these are really great for the consumer. But as I look at it, it's actually in their own best interest. So they'll send information about, we have a confidential shredding, clinic over in your neighborhood coming up in April. And I think, well, that's a great service for me as a consumer, but looking at it from a prevention perspective, that's probably preventing a lot of headaches for them when they have to deal with the issues of fraud or identity theft or those sorts of things. Same thing with the company that collects my garbage. They make it easy for me to separate out my recycling, and they have these free e-waste days. And as I think about it, yeah, it's good for me, but it's also helping them to prevent having to spend a lot of money digging stuff out of their landfill, or trying to figure out what to do with all this electronic equipment. So maybe the exchange or the health plans could do something along those lines for their consumers where they advocate prevention. Anyway, that was my comment. My question, though, was, Anthony, you talked about a goal of having 2 million plus enrolled on day one. And it made me wonder either from a financial perspective or from a participation by the health plans, is there a magic number, or is there a target that makes either the exchange viable or makes it attractive enough for the health plans to participate in that? And I was wondering if you guys have looked at that, and if there is a target or a goal along those lines.
Yeah, so I think In terms of the size of the scale, the size of the exchange, the estimates are that it could be potentially anywhere from 3 to 5 million people, and part of it depends on 3 to 5, maybe even 6 million people, and partly depends on if you're using CHIS numbers, using census data, if you're using, what's your baseline in terms of coverage. But there's at least 1.5, if not 2 million people who will get significant subsidies in the exchange as individuals. There's probably another million folks who could go into the exchange as individuals, and although not necessarily with subsidies. There's also something we haven't talked about, but I think is very important, is that there's a second. The exchange will actually run 2 purchasing pools. A second one will be called a shop exchange for small businesses to participate, and they will actually that will be the way that they can access a small business tax credit, some of them. So again, you add these all populations up, you could get into the several millions of folks, potentially a RAND study that came out a couple of days ago had it as potentially 20% of the overall market, which is pretty significant. I do think that it's important to get some critical mass. I think, again, and in terms of negotiating ability, let's remember that CalPERS, which is the second largest purchaser of health coverage after the federal government, is, this will be a magnitude of order bigger than CalPERS. And so I think that you have the potential to do it. California is big enough that it will have, I think, a critical mass to start with if we get the people who are enrolled in. And we have some good head starts. We have potentially 300, 400, 500,000 people who will be in county-based Medicaid expansions that have started to taken a hold because of the waiver. We have, again, the parents of Healthy Families children. We have Family Pack, which is, you could get up to a million plus right there. So I think this is entirely doable if we as California set a goal for it.
Okay, let's take another question. Let's make sure we hear from the audience, if you would, Patrick. Yes, Rita.
Well, I usually don't like for people to stand up and make a comment instead of a question. My main question is actually for Kim, because just given and I think you have a complete appreciation for this, given the expectations, so that this doesn't become a Christmas tree, but given the expectations, what is the timeline for the health insurance benefit exchange to begin to be active, to pull together what it's going to require in order to be ready for 2014? I mean, I just think about the IT aspect of it, and changing eligibility and enrollment systems, much less the outreach to people who never have anything to do with us, having to do with state or county services, because there's a lot of them. You have a pin?
Okay, so you give me an opportunity, Rita, to put on my 2014 is tomorrow pin. 2014 is feeling almost like yesterday, though. So big TikTok to all of us. California is in, I think, has a very solid foundation upon which we can move forward. Like I said in my comments, I think our legislature made some very important and strategic decisions in terms of the authorities and tools and operating model that they adopted. But clearly time is of the essence, particularly, as you note, around eligibility and enrollment, and I would argue there's no issue around which I feel any greater sense of urgency than our understanding how we can best move forward, both from a consumer perspective, an affordability perspective, and a federal government approval perspective. I'm hopeful. The expectation is that the Exchange Board will have its first meeting later this month. At that time, we will make some initial important decisions, namely to name an interim executive officer or administrative officer and undertake the process that will yield, in some respects, what may be the single most important decision we make, and that is the hiring of the executive director. But it's not like there's nothing going on. I want to acknowledge the work that the previous administration undertook in terms of really laying a responsible foundation from an implementation planning perspective, and the activities of the new administration in terms of building upon that, notwithstanding the very inappropriate high priority that is placed on our state budget problems. There has been ongoing work led through the Health and Human Services Agency and the Department of Healthcare Services. There are conversations going on to explore what options we can fully consider and develop to bring to the exchange, and working with our foundation partners as well to tee up the initial series of meetings to maximize their success. So I would hope within the first meeting or two we will be very clear about priorities and timelines and deliverables over the course of the next 6 to 9 months. And California is going to have to really recharge its batteries and get going and be in a position to submit an application for federal establishment grants, or which are basically the federal funds to support implementation. That requires the development of a business plan and a variety of other tasks that I'm confident we'll be in a position to do. But it's going to take a number of months, and I, along with all of you, are eager to get started. And I know Secretary Dooley and Susan Kennedy and Paul Fuhrer are as well. And hopefully there will be a fifth member to this 5-member board, but I don't see that necessarily precluding the first convening of the Exchange Board.
Thank you, Kim. Next question.
Did you just say that you could meet without a fifth person?
The question was, can we meet without a fifth person? And as long as there's a quorum, we can meet. Ideally, we would meet with a full complement of members, and hopefully that will happen soon, but I don't know if that necessarily is the definitive barrier to us meeting. So I'm anticipating we will meet within the next couple of weeks.
So Kim, let me put you on the spot a little bit. So are you saying, in terms of the pace right now, that you're neither complacent nor deeply concerned? Are you kind of somewhere in the middle?
I'm always deeply concerned. Anyone who knows me knows I'm always deeply concerned because we got so much work to do.
Yeah.
You know, it's a great opportunity. And like I said in my comments, I think we are in an enviable position. Our colleagues around the country are all, you know, it's like hair on fire. Can they get a bill? And can they get a bill that provides the structure and the tools to actually do something meaningful for the people of their respective states? So, yeah, you know, we've had some distractions, and there are understandable distractions in terms of the very real fiscal crisis that we continue to be in. And that crisis does not exist independent of our work together in terms of standing up an exchange. You know, Diana Dooley spoke to this earlier in the week, and she, I think, properly said there's a cognitive dissonance between, on the one hand, standing up a big new federal program, even if it is off in 2014 and funded principally by federal funds. At the same time, we're looking at taking down Medi-Cal. And potentially even deeper cuts, given the inability to close the balance and the gap. So I am still I am sobered by the amount of work we have done, and I am optimistic by the structure and the tools we've been given, and the dedication of a diversity of stakeholders, our funders, the super smarty pants, who we all are going to come together, and we're going to make this work. But we need to get on with it. We have big decisions to make, and that's why I'm encouraged by the expectation that we will have our initial meeting later this month.
Thank you. Yes.
My name is Beverly Saldivar. I'm with the American Cancer Society, and I work with a lot of the underserved communities. But I'm not aware of the board, who's on it. Do you have some consumer advocates that are sitting on this also?
Broadly speaking, I would hope we would all be characterized as consumer advocates, because at the end of the day, we are purchasing on behalf of the millions of Californians, consumers, who stand to benefit most significantly by our standing this up as effectively and strategically as possible. The legislature, in terms of the legislation enacted last fall, policymakers provided clear direction to the appointing authorities. And in the interest of time, I didn't get into this in detail, but it's a 5-member board, 2 members appointed by the governor, 1 member appointed by the Senate leader, 1 by the Assembly leader, and the 5th is what we call an ex officio member, and that is the Health and Human Services Agency secretary. By virtue of that person serving in that position, serves as a voting member. So those are the 5 members. The legislature was very clear in terms of the kind of qualifications and expertise that board members were expected to bring to their positions, and it was principally focused on health plan purchasing, health plan administration, both commercial insurance as well as public programs. and also provided very clear direction in terms of conflict of interest, that members of the board cannot basically receive any financial resources from health plans and insurers, agents and brokers, providers. So it's a very high bar, both in terms of the level of expertise as well as the conflict of interest provisions. Other states have taken a different approach in terms of saying we want a larger board, and we want 1 seat for a consumer rep and 1 seat for a plan rep and 1 seat for a business representative. California policymakers took a different approach. And so Governor Schwarzenegger appointed myself as the former Health and Human Services Agency Secretary, Susan Kennedy, his former Chief of Staff. Speaker Perez appointed about a month or so ago a gentleman named Paul Fuhrer. Mr. Fuhrer has been a longstanding chair of the Pacific Business Group on Health and has been a purchaser on behalf of Union Bank for many years. Secretary Dooley, who's the new agency secretary, and the final appointment will be made by Senator Steinberg.
Thank you.
So Chad, do you have any observations on how we're doing in terms of those appointees and the composition of the board, and maybe any expectations? Any expectations for that final appointment?
It needs to be a Latino. Because one of the other things in the law also is that it respect and observe the diversity in California. So I don't see a representation of people of color on the board thus far. Although there is great talent there, I think I would like to see the last appointee be a person of color.
Okay. I think we have time for one more question. Please be quick.
My name is Beth Abbott. I work for Health Access California, and this question in no way reflects my boss's opinion on the panel. But in the interest of Mr. Zingali's request, we stir things up a bit. I wanted to ask Mr. Johnston whether or not, in light of your very supportive statement about the exchange and the role of health plans, if you found that the individual mandate was not an ongoing part of this healthcare reform, do you believe that that loss of that requirement would still require health plans to participate fully and actively and supportively of healthcare reform?
Yes.
You heard it here, folks.
Do you want to elaborate on that, Patrick? Because obviously, let's be honest, the individual mandate remains vastly unpopular in the nation, even here in California, to some extent. I know your members have strong views about its importance.
Well, we talked about health coverage and health care a lot today. We didn't talk too much about costs, although, you know, it was referred to by Anthony and others. But health care is really expensive. It costs a lot. And the sicker you are, the more it costs. That's why care is good, because we have experts and we have medicines that have been developed and all that. So there's a big cost to it. So the question is, how do we share the cost burden? This isn't like going to Costco or Nordstrom's. This is your health care and your neighbor's health care. So the policy debate that's still going on in Washington is, are we going to share or socialize those costs over as many people as possible? Insurance calls pooling it. Who's in the pool, right? Well, if you're real healthy, you'd like to be in a pool of just healthy people because it'd all be cheaper. The Congress and the President opted for the biggest pool possible, and that's what an exchange helps to do, is get as many people in it. However, some people are not going to be in the exchange. The question is, should they still have coverage? Well, if they're poor, they're going to be eligible for Medi-Cal and healthy families, and that's good. But if they have income, should they be required to pay or not? The way to share the burden and therefore minimize costs on people who drive costs higher, which we all will from time to time and eventually probably, is to require people to have coverage. Some people have decided to focus on that individual mandate and only talk about that because it's unpopular to say you got to do something. But arguably, it is the best way, short of doing it entirely through the tax system, which was an option. They didn't choose that. In other words, you could just say, we're going to pay higher taxes, and that'll pay for all the health care. That's one way of doing it. So the individual mandate may be adjusted, tampered with, potentially even eliminated, but it is unlikely that many of the other attractive features of the Accountable Care Act will be removed, so health plans will follow the law and comply.
Thank you, Patrick. And Patrick's going to have the last word on behalf of the panel. Thank you guys for your attention, for being here, for your questions and comments. This is a great group of, you have pretty much everybody here from all facets of those of us who are going to be counted on to make this work. So I know you take that responsibility to heart. We're going to rise above our parochial interests when we have to and work on behalf of all those people of California. So let's go get them. Thank you. And thank you very much, panel. You guys were great.